Remember that both the nervous system and skin develops from the ectoderm, so it makes sense that there are a number of congenital diseases with both neurological and cutaneous manifestations. The four that are most commonly seen are Sturge-Weber syndrome, tuberous sclerosis, neurofibromatosis, and von Hippel-Lindau disease. Sturge-Weber syndrome is a sporadic congenital disorder that occurs equally in both sexes. Babies usually present with a cutaneous angioma over the head and neck. This is an image of the port wine stain distributed in the classic V1 dermatome. It is associated with focal or generalized seizures, hemiparesis, and mental retardation. Remember that V1 involves the eyes, so angiomas can develop in the choroid layer of the eye. These kids also go on to develop glaucoma. Tuberous sclerosis can be sporadic or caused by an autosomal dominant mutation in either the Hamerton gene on chromosome 9 or the tuberin gene on chromosome 16. These genes are tumor suppressors, so when you think tuberous sclerosis, think benign overgrowths or hamartomas. These hamartomas can occur anywhere, in the brain, the skin, visceral organs. Neurologically, the kids present with seizures, progressive psychomotor delay, and mental retardation. The skin findings include adenoma sebaceum, as you can see here, which may occur along the cheeks, the nasolabial folds, and chin. There are ash leaf spots, which are leaf-shaped, hypopigmented spots, and also shagreen patches, which are leathery plaques, usually on the trunk. Tuberous sclerosis is also associated with kidney tumors, which is renal angiomyolipoma, and heart tumors, specifically cardiac rhabdomyomas. The mnemonic hamartomas may help you to keep all these diverse findings straight. Neurofibromatosis can occur sporadically or can be inherited autosomal dominantly. Type 1 is due to a mutation in the NF1 gene on chromosome 17. It's characterized by neurofibromas and café au lait spots, as pictured here. Other skin manifestations include freckling in the axilla and hyperpigmented macules. Neurological manifestations include involvement of spinal or cranial nerves, meningiomas, gliomas, and hydrocephalus. The image on the right here shows characteristic Lisch nodules, which are basically pigmented iris hamartomas. Also, bony overgrowths are commonly associated with neurofibromatosis, as are bone cysts and scoliosis. Finally, von Hippel-Lindau disease is caused by an autosomal dominant mutation in the tumor suppressor VHL gene, which is on chromosome 3. It's characterized by hemangioblastomas in multiple body parts. They're commonly found in the cerebellum, where they would cause ataxia and headache. Retinal hemangiomas, as you can see in this photograph, are also characteristic of VHL and are diagnosed by fundoscopy. VHL is also associated with renal cell carcinoma, which is a common cause of death, and pheochromocytoma. Alright, now we're going to discuss brain tumors. The most common brain tumor is actually any sort of metastatic brain tumor. So, what are some common tumors that metastasize to brain? Correct, lung. That's the major one. Others include breast cancer, melanoma, lymphoma, renal cell, and GI tumors. Now, most primary brain tumors arise from glial cells, and thus these tumors are called gliomas. Other common primary brain tumors include meningiomas, which arise from the meninges, pituitary adenomas, and neurofibromas. Try to pay attention, as this is definitely a high-yield first aid fact. Now, there are different ways of classifying brain tumors. You can start with whether the tumor primarily presents in children or adults, and then whether the tumor presents in the cerebral cortex, known as supratentorial, or those that present below, infratentorial, meaning the brainstem or cerebellum. The symptoms that the patients present with differ depending on where the tumor is located. Symptoms that should raise suspicion of underlying tumor include new-onset seizures in middle or late age, as we had already mentioned, focal neurological lesions, headache, and also dementia. Diagnosis is typically made by CT or MRI. Metastatic brain tumors usually appear as multiple lesions in the brain, while primary brain tumors usually only show one mass. As for the different types of brain tumors, I'll mention some of the most salient points, but it's worth spending some time memorizing the different characteristics of these tumors and reviewing their histology. Glioblastoma multiforme is the most common primary brain tumor, and unfortunately also the one with the worst prognosis. It's the most advanced grade of astrocytoma, which is differentiated based on the degree of differentiation of cells, with grade 1 being most differentiated and grade 4, the worst grade, being the least differentiated. Even with our most advanced treatments, fewer than 20% of patients survive 1 year after symptom onset. GBM is usually found in the cortex, and the classic sign on imaging is that it crosses the corpus callosum to the other hemisphere. The word multiforme comes from the mottled and heterogeneous appearance of the tumor. It is so big that areas of it are necrotic and others are hemorrhagic. Histologically, you'll see a lot of cellularity, pseudopalisading pleomorphic cells with nuclear atypia, and also positive staining for GFAP. Meningiomas arise from the dura mater, or the arachnoid layer. On imaging, you'll see a circular mass from the meninges compressing the brain parenchyma. The tumors generally favor the falx, which is where the tumor is arising in this image, the meninges overlying the hemisphere, and also the parasagittal regions. Histologically, meningioma cells are relatively uniform, and they form whorls and psammoma bodies. The treatment is with surgical resection. Now schwannomas. Remember what Schwann cells do? Correct, they myelinate the peripheral nerves. A tumor arising from these cells would be called schwannoma. The most common schwannoma arises from the vestibulocochlear nerve, that's cranial nerve 8, and is widely called an acoustic neuroma, which is actually a misnomer as it's not a neuroma but rather a schwannoma. You can return to the vertigo entry to review. Recall that these patients may present with central vertigo. If there are bilateral tumors, this would be highly suggestive of neurofibromatosis type 2. Oligodendrogliomas are rare, indolent tumors that prefer the frontal and temporal lobes. So what do you think the patients present with? How about in the temporal lobe? So in the temporal lobe, think seizure. What about in the frontal lobe? There you'd be concerned about a focal hemiparesis. The tumors are often calcified, so you should be able to see that on CT, and histologically, the cell has a small round nucleus and a halo of unstained cytoplasm, so some think that it looks like a fried egg. Pituitary adenomas are discussed more in the endocrinology lectures. The thing to remember is that unlike the other primary brain tumors, which present with symptoms of mass effect, pituitary adenomas are often noticed because of their endocrine symptoms, though they can have some mass effect on the optic chiasm.